everyone, and welcome to this session focusing on prejudice, stigma and discrimination around both HIV infection and disease. The session is called a workshop because there will be a number of occasions throughout that I'd really appreciate you reflecting on and then feeding back to each one of us on your Moodle site forum discussion zone. And then I can get back to you, especially within the first week of this presentation being uploaded, and help respond to some of your reflections or questions and queries that you may have. By the end of this session, there are certain outcomes that I'm really hoping we can achieve. First of all, to give you the opportunity to explore some of the personal assumptions and values and beliefs around HIV, AIDS and related stigmas and discriminations within the safe learning environment of this particular course. You'll also have the opportunity to consider some of the theoretical perspectives and influences, both around HIV and how stigma can impact on people with HIV infection and disease, especially from the point of view of our own societies and the prejudices inherent within them. For those of you studying the course at level 7, you'll also equally have an opportunity to critically reflect on some of the ethical issues that impact on HIV infection and disease, and to critically explore these in relation to your own professional practice. It's a sobering thought to consider that in 2015 there is still no cure for AIDS and sadly still no vaccine against HIV. As you've been studying on this course, presumably you're well aware of many answers now to questions around HIV. So if you'd like to test yourself, then I would really recommend you have a look at the quiz on the website shown at the bottom of this page, and that's provided by the National AIDS Trust. If your working environment is a smoke-free zone, it's easy enough to put up signs and stickers to alert people to the fact that smoking is not allowed. But how do we get a message across that stigma isn't allowed? How are we meant to show people, especially those suffering under the burden of HIV-related stigmas and prejudice, how can we show them that our services are in fact places of safety for them, where we celebrate diversity and take all steps possible to get rid of prejudice, stigma and discrimination? In 2003, the International Council of Nursing produced a document called Nurses Fighting AIDS Stigma and Caring for All. One of the opening sentences within this work said that all that will stop HIV prejudice is speaking openly about the facts. When I first read that, I thought, well, it's a lovely thought, but maybe it's not the whole truth. Because even when we know the facts, say for example as healthcare professionals, and we know about how to practice universal precautions, what we should do to minimize any risks of HIV transmission within the workplace, for example, then we still hear prejudice and stigma as they manifest themselves within certain colleagues who wish to take over-the-top precautions around caring for people with HIV. So I would suggest it's not just talking about the facts of HIV that can enlighten people, but that there is more that needs to be done that we'll actually explore throughout this session. Right from the early days of HIV and AIDS, it's not as if in 1981 simply a new infection or a new condition was discovered. It's not like in 1981 somebody discovered diabetes, for example. When AIDS was first labelled, and then 4 years later when the virus was renamed to HIV, both of those names, both of those conditions actually tapped into centuries of hostility, prejudice, stigma, discrimination around different aspects of life, especially sex aspects, sexuality aspects, and for people who were seen to be doing things that the majority in society weren't too comfortable with or weren't happy about. So when AIDS was first labelled, and then later when HIV was given its name, I would suggest that both of those conditions already brought with them a baggage of stigma and discrimination in most societies around the world. So already I've been using a few different words here. I'm often talking about stigma, prejudice, discrimination, and we might stop to ponder for a moment what we actually mean by some of these different terms. What's the difference between them, for example, especially when we're talking stigma or stereotype? Maybe just pause a moment and consider what you think are the differences between those two words. What's the difference between stigma and stereotype? If, like me, you are happy to find out the origins of words and how they've changed over the generations, for example, there's a really good website shown on your page at the moment which explores the etymology of words. That means the origins, the meanings of different words. So let's return to the first two here, stigma and stereotype. It would be really good to know what your answers were to the question, what do you understand about the differences between these two words? Please feel free to jot down some answers on your forum, on the forum site on your Moodle course. Well, stigma actually comes from an ancient Greek word that means a mark or a sign. So the very fact that I'm wearing glasses, for example, that's a mark, that's a sign. It's saying to people that there's something wrong with my eyes, that I can improve them by actually wearing glasses. So that's the origins of that word stigma or sign. Quite often, however, in many societies, a stigma is often perceived in negative terms. So somebody might be a fantastic athlete, for example, but we don't refer to that to their athletic prowess as being a stigma. So the term has evolved gradually over the centuries, often to mean something which is perceived negatively within societies. Now, whether it's something visible, say for example, if I were a wheelchair user, then automatically you'd be able to see that I was sitting in a wheelchair. But with conditions such as HIV, for example, they're normally hidden from the general public and they're known to the individual. If that individual perceives their condition to be a stigmatized condition within their society, for example, then they may actively try to conceal the fact of their HIV status. And within stigma theories, a lot of work has been written about something called concealability and course. So, whether somebody's intentionally hiding something about themselves, what's going to be the course or the outcome of them trying to conceal it? Or if in fact they actually do come out about this stigmatized condition, whatever it is, what will be the course of that, especially amongst other people that they're living and dealing with? If we move on to the next word, stereotype, that originates from the idea that there's two or more of something. So a stereotype is often a way in which we make a quick prejudgment, a prejudice, about an individual. So if you know, for example, if you think you know what all Welshmen are like, and then all of a sudden you hear my accent, or you know that my name is David Thomas Evans, you might think, well, I know what he's like because I know what all Welshmen are like. And that's what stereotype means. So the very fact that somebody has a particular stigma might be the identifying mark that shows them out to have this stereotype. There's more than one of them. And when it comes to prejudice, certainly the origins of that would be to prejudge somebody. So if you've already made up your mind about a person because of a particular condition, in this case HIV, for example, and then you meet somebody with HIV, you've already made a prejudgment. You're expecting them to behave in a certain way, or even expecting you to relate to them in a particular manner. If that way of relating happens to be negative towards an individual, then that's what we mean by discrimination. So discrimination, more often than not, is a negative term, and it's often bound with hostilities towards working or caring with There's a famous French philosopher called Michel Foucault who died in 1984, and Foucault spoke about something that he called the triple edict, and by that he was referring to anything in life which happens to be covered by a taboo, such as, for example, HIV or AIDS. So if people in a particular society treat an aspect of life as a taboo, then generally they don't talk about it. So it would appear that it doesn't even exist. And that's one of the problems that we have in the UK in 2015 in relation to HIV. Over these last years, the numbers are still increasing of people who are newly infected with HIV, and now we have almost 100,000 individuals living with the condition across the UK. And yet I would argue that it's probably one of the health conditions that's least spoken about, especially from the point of view of active prevention. So when you consider that lots of people newly infected with HIV happen to be under 24, for example, then we should ask ourselves what schools are doing to raise awareness about HIV. And it's not just raising awareness about the condition in itself, but how people can prevent acquiring the infection in the first place. And I'm sure you will have already covered 3 critical areas around HIV infection, which are to do with the quality of the virus, the quantity of the virus, and the route of transmission. If all 3 of those conditions are high, so you've got good quality, good quantity, and there's an open route of transmission, then of course HIV can pass from one person to another if an individual, of course, is HIV to start with. But how many young people are actually educated and given the skills and the resources to protect themselves against HIV? So it's not just raising awareness of the condition that we have 100,000 people living with it in the UK, but how can more people prevent the virus spreading from one to another, and how can we empower individuals to take care of themselves and be able to protect themselves? I'm sure most of you are aware of a phrase that was coined by Thomas Kuhn many years ago when he spoke of a paradigm shift, and that usually means ways in which we're thinking about something and how they change, maybe over time. Foucault looked at it from a slightly different perspective, and he referred to a paradigm shift as an epistemic transformation. Now, by episteme, Foucault understood the ways in which we understand things. And he wasn't just keen in looking at how they changed over time, for example, but what he was most interested in was what he called the dislocations. So breaks or fractures in the ways in which we used to think about something compared to the ways in which we think about it today. And if you look at some of the images on your screen at the moment, there is a clear epistemic transformation going on in the imagery around HIV. In the top left-hand corner of your screen, for example, there's a photograph that was used on street billboards around the world, especially here in the UK, from the clothing company called the United Colours of Benetton. And they used this image to be provocative. In fact, it probably backfired on them quite a bit because it was seen as totally unethical and inappropriate to use the image. The man in the bed had actually just died a few moments earlier, and the photograph was shown. The photograph was taken of his family as they surrounded the bed. They were caring for him in the last moments of his life as he died with an AIDS-defining illness. So, especially in the 1980s, for example, and early 90s, the idea of death around HIV, and especially around an AIDS-defining condition, was paramount in many people's minds, and even people talking about HIV as being a death sentence. When you look at the next top picture, showing a young man taking a massive capsule, of course the pills were never that big, but there was a time when people were going through a period called pill burden, because some individuals living with HIV may be taking well in excess of 20 or 30 different tablets a day. And it was as if their whole, not just their waking lives, but sometimes their sleeping lives were dominated by the fact that they had to take certain medication. Sometimes that would be taken with food, without food, during food. There were all these strict regulations that many people found it being a pill burden. Now look at two of the bottom images, and the one showing a young man with a big smile across his face, and it's talking about rapid HIV testing in 60 seconds. Wow, you can't wait to go out and get this. The whole image has completely and utterly changed, and it's being portrayed in a very positive way now. Not only has it put a smile on this man's face about going for HIV testing, but you can get it done in a shorter time than 60 minutes. When you look at the other bottom right, the right-hand corner image, showing a man sitting in an electric chair, so obviously trying to draw on images around a death sentence, and look at the language that's being used. So it's tapping back to the early 80s, where many people thought of HIV as a death sentence, but now the epistemic transformation that's taken place is not that HIV is a death sentence, but not knowing one's status might be. So the whole emphasis has changed. And again, in the early days of HIV, when there were no effective treatments to help people manage and live with the condition, the whole idea then about testing was, well, why have it done? What can actually benefit an individual by being tested? Now the whole emphasis is the exact opposite of that. The continuing motif within the middle, silence equals death, that was as important in the 1980s around HIV as it is now today. Silence equals death was a motif used by an organisation called ACT UP, the AIDS Coalition to Unleash Power. And it was individuals affected with or infected by HIV who felt that their governments just weren't taking the issue seriously. And sadly, the British government at the time has often been accused of that as well. So it was individuals that were actually fighting for more of a voice. When Foucault speaks of the triple edict of taboo, non-existence and silence, definitely ACT UP were trying to counterbalance what many people saw in their societies as the taboo, non-existence and silence around HIV. And a lot of that was created because of the stigma around the ways in which HIV was transmitted. So, for example, gay males, injecting drug users, in some countries it was commercial sex workers. There were lots of people that were seen to be doing things that their societies already stigmatized, and now there was an infection associated with that. It's also really crucial to look at the ways in which the media report some of these issues as well. Say, for example, if a baby is born with HIV, look at the way in which the media actually talks about innocence. This poor innocent victim, this little baby, who obviously didn't ask to be born with HIV. But Susan Sontag in 1991, when she wrote the book AIDS and Its Metaphors, she would say that the moment we use the term innocence about one person, so if you say, oh, this poor little innocent baby born with HIV and the baby didn't do anything to ask for it, but just consider the terminology, consider what we're saying and the symbolism about it. If you're saying that one person is innocent, then what's in the silent implication about the other? So the silent implication is obviously that somebody else might be guilty. And it's that guilt that's been a burden that many people have carried with HIV, because it's so often associated with stigma, the mark or the sign. When we consider our own society, for example, here in the UK and different societies around the world, I would suggest that there are 7 main pillars in society that we can think of that really have a great influence, not only around HIV, but on the stigmas, the prejudice and the discrimination attached to this infection and the disease. When you consider the role and impact of religion in many societies, although in the UK, arguably, the impact of religion is falling on many individuals, and yet down throughout the centuries, it's religion that's actually influenced the whole of our lawmaking procedures. So whether laws are promulgated through the courts or enacted through parliaments, it's those voices that are actually deciding everything, even down to HIV funding, for example. And when you consider the way in which some people around HIV are considered to be guilty, then when there's a shortage of money for the NHS, for example, look at the way in which people talk about some conditions are deserving cases. But again, if you say that a person with one condition deserves extra money, extra treatment, they deserve it, what's not being said about others? Also, it's these societies, the religions, the laws, the promulgations through Parliament, that actually define what we understand by family life. Over the last couple of years, there have been many ways in which anti-discrimination has moved ahead at a great pace within the UK, especially around sexualities, and it's made all people equal, whether that's in relation to age of consent for sex, being able to marry, being able to adopt and have children. So lots of things have changed. But the UK is one of the few countries around the world where this is happening. Even within the British Commonwealth, for example, the majority of nations still have laws in place that discriminate against people on grounds of sexual orientation. Even in a country that we often assume to be highly democratic, such as the United States of America, there are some states within America where same-sex couples can't marry. Okay, so I'm building up a picture here of these 7 pillars in society because they have a huge influence on the way in which we think about aspects of life, and especially in relation to stigma and discrimination. Even within academia, whether we're talking schools, right through to universities, to people who think a lot. So the whole aspect of our knowledge, again, has often been affiliated with a lot of stigma and discrimination against particular individuals. Even the fact that here in Britain, in those early days of HIV, when the government brought in something called Section 28 of the Local Government Act, the impact of that was huge stigma and discrimination on individuals because of their sexual orientation. And healthcare professionals and our healthcare world sadly are not immune of discrimination and prejudice themselves. Even when you consider that homosexuality, for example, was considered a mental illness until about the last 40 years. The way in which older lesbian and gay people that you may be treating will have some real horror stories to tell about their mental health and well-being and how this was dealt with by professionals many years ago. And fast forward now to the times of HIV and look at the way in which many hospitals had to open up an HIV ward, for example, because carers on other wards or departments weren't too happy caring for people with HIV, or the individuals with HIV would say they had such a bad time on many of these general wards that they would prefer to be with people like themselves. And again, think of the impact of not just the armed forces, but prison services, police service, and the way in which these exercise an ethos of governance, as Foucault would say, governmentality, how they make sure that the society carries on practicing laws that have been promulgated by Parliament and the courts. And also the media, the huge impact of the media, especially around issues of HIV. Even today, if you read some of our British newspapers, just read between the lines and spot out the prejudice and discrimination. And of course, what I'm arguing with these 7 pillars of society, that these actually form the way in which many societies operate and function. They're the pillars in society which decide what's to be considered good, and the opposite of good, of course, is evil. So it's many of these organizations in society that define the way in which a society is meant to function and to think and to process its citizens. And yet, especially in the case of HIV, this has had a very negative impact on many people in their lives. So here's a brief task that I hope you'll come back to and then certainly reflect on and give us your ideas within the forum site on this Moodle course. First of all, just draw up a list of what you perceive as one or two of the most significant prejudices, stigmas, discriminations, or invisibilizations to affect your practice area in relation to people with HIV infection and disease. So, for example, if you're working as a practice nurse, you may say that within your practice, there's no recognition of HIV at all. There's no encouragement for people to be HIV tested. There's no safer sex awareness. There are no free condoms available. There are lots of ways in which HIV and preventing HIV are completely invisibilized within your service. Okay, so put that down on your list. So dot down a few ways in which you think there's prejudice, stigma, discrimination, or in which HIV is hidden. Then, when you've drawn up a list of some of these issues or matters, try to identify from the 7 pillars we've just looked at, try to identify where you think the major influence is coming in relation to that. So say, for example, if you're working as a school nurse, and you might say that within sex and relationship education, very little is being said at all about non-heterosexual sex. And you might say, well, I think that's the legacy of Section 28 of the Local Government Act, that even though it was scrapped back in about 2000, many schools have failed to fill the void with positive action. So you might have young gay boys, for example, growing up in school today, that when they go to sex and relationship education classes, that's all they're hearing about is reproduction. And if they think that that doesn't affect them at all, but what they are interested in is fancying the boy sitting next to them, and yet nobody's talking about HIV, nobody's talking about condoms. So a lot of young people are growing up thinking either that HIV has gone away or that there's some sort of cure for it. And that in itself boils back down to a lot of stigma and discrimination. And finally, just explore ways in which you think this can have an impact on your clients and on your particular setting. So say, for example, after doing this course on HIV, you may think you're going to become proactive in actually talking about HIV to your clients. But you might find that you need to talk to your colleagues first, because some of those might be rather resistant to talking about it. Or if an individual client comes in and says that they want to talk about HIV, everyone who mentions it gets passed over to you. So you might have to start with your colleagues, not just with your clients. Jonathan Mann, who was one of the directors of the organisation called UN AIDS, said that we're not just dealing with one pandemic of HIV around the world. Neither are we dealing with 2 pandemics, one of HIV and one of AIDS. He said that stigma is so endemic around HIV and AIDS that the world is actually coping with 3 pandemics here. And when you look at the different aspects, whether it's to do with HIV or to do with AIDS, look at the way in which the stigmas may be different there. So, for example, from the point of view of HIV, somebody might be really fearful of acquiring the infection. So it's all to do with contagion. Even the plague motifs of the early 80s, for example. But then, when you consider AIDS, because for some people they may have an AIDS-defining illness which is actually visible to others or known to others, then the stigmas can actually shift there, and especially with blame, and that often leads for many people to being isolated. So not only may they be suffering with an AIDS-related illness, for example, but they may have the impact of stigma, which will have very detrimental effects on their mental health and their mental well-being. But not only are we thinking of these 3 different pandemics here, but we also need to consider us as individuals with our own knowledge, attitudes, feelings, and beliefs. So, what do your individual colleagues actually know about HIV? And if, for example, someone says, well, if I'm caring for an HIV person, I want to put 2 sets of gloves on. That's completely wrong, of course. So we have to work with their level of knowledge here, and certainly impart the facts to them that wearing 2 pairs of gloves might actually put them more at risk. But also, it's people's attitudes. And when we go back to consider fear, stigma, blame, guilt, innocence, that's a lot to do with people's attitudes. And that can tap in then to their gut feelings. So they might feel that they've got unconditional positive regard for some individuals, and yet when it comes to a stigmatized condition like HIV or like AIDS, then they may start making prejudice, and actually act on that in discriminatory ways, and that taps into then their behaviors. But also we need to realize that a lot of the knowledge, attitudes, feelings and behaviors are actually based on a person's notion of self-protection, especially in the early days of HIV, just as at this moment in time, if we think of Ebola, look at the ways in which people want to protect themselves and those that they love, that they don't want to be putting themselves at risk. And in the early days of HIV, when very little was known about it, some people went overboard with self-protection, and I would argue that because there's not sufficient education of health and social care professionals happening now today, that there are many who are still stuck with these notions that we were struggling with in the 1980s. And also impact right across all of this the 7 pillars of society, the structures that we recently explored. For individuals and the worlds in which they live, we've also got to realise that a lot of the stigma and discrimination can be internalised by individuals, and the more it's internalised within them, it can have a detrimental impact on their mental health and well-being. And not only is it going to be internalised within them, but interpersonally with themselves, with their partners, their lovers, their families, their friends. There are ways in which individuals are actually treated because of their HIV status. And even if that status isn't known to others, if it's kept secret within an individual, that secrecy itself taps into those notions I mentioned earlier about concealability and then the outcome or the course of such concealability. We've already looked at the 7 pillars of society and so many ways in which the fear and stigma can be embedded within our cultures and within our various institutions. So the fact that schools do very little around HIV awareness, which is effective to each and every individual within that school, I would argue is a clear case of overt institutional discrimination. Again, looking at it from the point of view of the individual and the society in which they live, some of the social differences can include stigmatizing others for their difference. Look at the ways in which HIV positive people have often been isolated in many different societies and walks of life. And it means treating them negatively, treating them differently. But also one of the biggest problems, of course, is denial that HIV not only exists, but denial in the way in which it's passed from one person to another. And the little blurbs popping up around your screen show the way in which so much of this social difference can actually impact on the individuals. And at the bottom of the screen, it's showing you ways in which all of that is actually supported. So there's misinformation, for example, the ways in which people think that HIV is passed or can be cured or not cured. Look at some of the myths around the world, for example, and you'll see that there's so much misinformation going on, which of course is tapping into stereotyping. And the invisibilization of HIV, the very fact that we have 100,000 people living with it within the UK. Now, presumably at some point or other, for whatever reason, maybe even to have their appendix out, these people are coming into hospitals or using healthcare services. And yet there are so many healthcare professionals who still have not done adequate education around HIV to be able to work effectively with the individuals who are affected by the condition. And what this is spelling out is not just stigma and discrimination, but a complete and utter lack of equality. It's treating some people differently to others. And usually in our societies, when you look back at those pillars, Anyone that ticks all the boxes for those 7 pillars certainly are those who are privileged within society, and those who don't would be judged opposite to that, and that's where there's a complete and utter lack of equality. But let's not consider that all of this is really negative. What we actually have to remember here, like with the early days of ACT UP, the AIDS Coalition to Unleash Power, it's created a force for good, a force for equality and freedom within individuals and within societies. So a lot of the self-help and action groups have started off with people who are HIV positive in the first place because of the hostility many have felt from their societies, and it's ways in which they've positively dealt with that to make sure that they're not downtrodden victims. So what we need to focus on then is to capitalize on the very fact that some people are working for equality, for greater awareness around HIV, and many ways in which stigma and discrimination can be eliminated, especially within our health and social care services. To do this is always good to be clearly evidence-based, so that we can go back to the evidence base and say, here's something that works. And especially if that document has a voice of authority with it, for example, then it's ways we can have a positive impact within our own working areas. So what I'd like to share with you for the final part of this session are 10 strategies to counter discrimination that were published in 2002 by UN AIDS. The first of the 10 strategies talks about decreasing the myths and misconceptions about HIV and fighting ignorance. The very fact it's written as HIV/AIDS, I really need to say something about that, because I know this is the usual way for it to be written, and especially as the word AIDS was invented before HIV, that many people often use the word AIDS when in fact they ought to be talking about HIV. So there's some confusion there, and we need to dispel that. But also, HIV and AIDS are not identical. And even the stigmas around HIV as an infection or AIDS as a clinically indicated disease can be very, very different. So I understand that the UN AIDS are talking about it as HIV/AIDS, but me as an individual, I'm not too happy using it that way at all. And that would be one of the ways of decreasing the myths and misconceptions. So if a person always uses the word AIDS, for example, because that's the generation they grew up in, and if they find out somebody is HIV positive, they might think, oh, that person's got AIDS. And then whatever stigmas and misconceptions they have about AIDS, they're applying to an individual because of their HIV status. And yet the two can be very, very different. So certainly sitting them down and talking to them about the difference between HIV and AIDS is one of the very first steps of challenging some of the myths and misconceptions. The second of the 10 strategies is to encourage people infected with HIV to tell their stories. There's one story I'd really like to share with you. I was fortunate enough to be speaking at an International Council of Nursing Congress in Taiwan a few years ago, and it was on the issues of HIV. And a woman from the Republic of South Africa spoke up, and she said, there's something I need to tell you all, and I think her story really needs to be told. She said, first of all, she made the statement, she said, well, those of you in the West haven't got a clue about HIV. She said, because where I live, in the part of South Africa I live in, she said, when I go to work, and I work night shifts, I work 12 hours each shift. We have 30 patients on our ward, and there's only me as a registered nurse and one healthcare assistant, and we have 30 patients to care for. Half of those patients, if they were in a hospital in the West, would be in an intensive care unit because they're so ill. She said, but after working an exhausting 12-hour shift, I have a 4-mile walk to get back home. When I get home, I then have to cook breakfast for my family so they can go to work and school. And the final thing she said is, and 50% of my family are HIV positive. So, getting people to tell their stories. there was an individual advocate around HIV who really told her story and the media quite well in Parliament just a few weeks ago at an all-party parliamentary group on HIV and AIDS. And she said she's been HIV positive for 25 years. And she regularly gives presentations on being HIV positive. She said, but as soon as she says to someone that she's positive, the very first question almost every single person asks, whether that's the media or healthcare professionals, is, well, how did you get it? She said, look, that was one tiny event 25 years ago. I've lived a 25-year, very positive and healthy life since. I'm at the peak of my career. I'm doing really well in life. And all they can focus on is how I got the virus 25 years ago. So really encouraging people with HIV to tell their stories, to normalise it. Say, for example, if you're doing a course on diabetes care, you might get a person with diabetes to come in and talk to you how they manage their condition. So why not raise the voice more of HIV positive people? Also, one of the strategies talks about how stigma and discrimination need to be part of the HIV prevention care programs. So when we're doing education around HIV, it's not just the facts alone. It's not just talking quality, quantity, route of transmission and how a person becomes infected or how they can prevent themselves from becoming infected. It's not just that. We have to acknowledge that these conditions are actually surrounded by stigma, fear and prejudice. There's an image on your screen at the moment that shows Princess Diana hugging a little child in one of the Latin American countries. And when she hugged that child, the child had an AIDS-defining illness. And Diana broke through so many barriers there. She actually said as she hugged the child, look, you're not going to get AIDS from hugging a child with AIDS. And the very fact that she was seen in some of the London hospitals shaking hands with individuals with HIV without wearing gloves, for example, cut through barriers at a time when they were real significant worries. But also, especially within the world of healthcare, we're often accustomed to hearing the message that if it isn't documented, it didn't happen. So we must be clear, you need to document acts of stigma and discrimination, whether that's from other healthcare professionals or other patients within a particular department, for example. If someone is discriminated against because of their HIV status, it needs to be documented. Otherwise, if it isn't written, how are we ever going to know about it? And certainly here in the UK, we've made great opportunities, and we've had great opportunities to actually change so many of the laws to become anti-discriminatory. And both HIV and AIDS are now considered under the Equality Act of 2010. So any form of discrimination on either of these conditions is actually against the law. Sadly, that's not the case in many countries around the world. As you can see from this slide now, promoting non-discriminatory laws, please feel free to get involved, even if it's on Twitter, for example, and you notice that in some countries there are laws which are detrimental to people with HIV. Get involved in the debates. Be part of the voice that's working towards change. And especially in these last in these last 2 decades here in the UK, for example, many ways in which healthcare provision and practices have really changed. So the first image on your screen is showing a fetus with a red ribbon, and the way that pregnancy has been totally transformed for the majority of people, the majority of women living with HIV. So great strides have been made there. And of course, you'll know that with modes of transmission for HIV, there are 3 opportunities in relation to pregnancy when a baby may become positive. So the virus, if the viral load is high enough in the woman, can pass through the placenta and infect the baby in utero. The biggest opportunity that it used to happen was during vaginal delivery, and then about a 15% chance of it happening through breastfeeding if the mother is solely breastfeeding for about a period of 5 months. The image of the huge tablet again, that goes to show how we've changed. So even from the mid-90s and late 90s, for example, when combination therapies were first becoming available and individuals had to take 20 to 30 tablets a day, now that's completely and utterly changed. Also, there's a sign on your screen talking about post-exposure prophylaxis. Now that came in, especially in relation to healthcare injuries back in 2000, and it was extended for sexual exposure around about 2002. Now there's yet another dimension of care where people can choose to go for pre-exposure prophylaxis or PrEP, and I'm sure you will have covered that on your course. So it's when an individual knows that they may be at risk through a particular act of sex, for example, where they may become HIV positive, then there's the opportunity to take the medication beforehand. So that's pre-exposure prophylaxis or post-exposure if they realise they've been at risk and weren't covered against that risk. And within your own workplace settings, make sure that you have clear policies and guidelines. If somebody says that they work in a department that practices universal precautions, and within those guidelines it says for universal precautions, make sure you wear gloves whenever you're in contact with a patient's body fluids. If an individual member of staff decides not to use gloves for one individual, because they assume they're not HIV positive, but then wears gloves for someone who is positive, then that's not universal precautions at all, because they're not treating people equally. In fact, they're discriminating against one person and the other. There's also another ethical concern here, that they may be outing people, they may be breaching confidentiality. If you wear gloves for one person and not for another, what are you saying about these two different individuals? So workplace policies may need to be updated in relation to HIV. And obviously, with our codes of professional conduct, whichever professional background you're coming from, we need to ensure that our codes of professional conduct really support people around not just HIV and around AIDS as a defining illness, but to combat the stigmas and the discrimination as well. And looking at ways in which mechanisms can address or redress all the discrimination that's happening. So 3 countries around the world that are in the news headlines for all the wrong reasons at the moment would be Russia, Uganda and Nigeria, who have all brought in very severe anti-gay laws just in 2014, 2015. They've brought in severe gay laws, and especially in countries where a lot of the gay males do happen to be HIV positive. By pushing a very orientation underground, means that it's even harder for these individuals to access the health promotion strategies they need to prevent acquiring infection and preventing them from passing it on to others. So look at ways in which you can actually raise this, maybe with your MPs, in your own parliaments, or on international organisations as well. If we take these 10 particular strategies and use education as a way of implementing these strategies. First of all, our education needs to be evaluative. We need to audit the way in which education is provided, check out whether enough is being done around HIV awareness. So all of you are on a particular HIV course. That's fine for you. This is like preaching to the converted. But how about people who are on an A&E course, for example? Who may see individuals coming into accident and emergency who might require post-exposure prophylaxis. How many A&E nurses realise that PEP is kept within their departments? And how would they know how to flag this up or highlight it with an individual, especially in non-discriminatory ways? So our education needs to be evaluative. We need to make sure that the education is fit for practice. And that practice is the health and social care that we're delivering to our clients. But it also needs to be enlightening, and as you will have seen from the slide on the pillars in society, there are so many ways in which our society is still burying its head in the sand. In those early 80s, the late 80s, the stigma, prejudice and discrimination around HIV was very, very severe and overt. It was in your face all the time. Now it's much more covert, it's hidden and invisibilized. So just because it doesn't seem to be around doesn't mean that it isn't having a negative impact on individuals. So our education needs to be enlightening. Say, for example, if somebody's doing a course on mental health, how might safer sex be an issue for a client with bipolar condition? So when they're manic, when they're really high, they might be going out and having loads of unprotected sex. When they're suffering with depression, for example, they may be really remorseful over this and weighed down by a burden of guilt. But do the mental health practitioners actually know about this? So we need education that's going to be enlightening of our colleagues. And by doing this, by assessing whether there is education in the first place, whether it's appropriate, whether it's enlightening, we're going to be empowering individuals, not just giving all of us as health and social care professionals a voice, but by us having a voice, being good role models to individual clients, many of whom feel that they cannot speak up about their particular healthcare condition. I thank you for listening to this presentation and really look forward to your feedback on the forum Moodle site. Go on to the course, click onto that particular forum and certainly give feedback to all the rest of us about your thoughts and your ideas, especially around these topics of stigma, prejudice and discrimination. Thank you so much for listening.